Welcome to Administration of Aerosolized Agents. This is Chapter 3 in RAUS, Respiratory Care Pharmacology. Our objectives today are to define terms that pertain to the administration of aerosol agents, to define aerosol therapy, and to select an appropriate aerosol medication nebulizer. We'll also discuss particle size and deposition in the lung. Some of today's objectives are to differentiate between the types of aerosol devices, describe the clinical applications of aerosol devices, and recommend the use of aerosol devices to your patients. So let's talk about some of the physical principles of inhaled aerosols. First, we're going to start with the difference between an aerosol and a vapor. Aerosols are actual particles of water suspended in a gas, and for us, this is usually oxygen or compressed air. A vapor is microscopic water in the carrier gas. So these are molecules of water or molecular water in a carrier gas. So aerosol, particles, actual physical little pieces of water, and a vapor, molecular water. Now, one of the big takeaways from that is with particles, an aerosol, particles, bacteria can be carried on that. For vapor with molecular water, it doesn't carry bacteria. Another physical principle is particle stability. Particle stability is defined as the tendency of aerosol particles to remain in suspension. Penetration. Penetration is the depth or how far into the lungs the particles reach. Deposition is where do the particles fall out of suspension and stick in the lung. Do they stick in the lung high in the lung? Do they stick low in the lung? Do they get all the way down to the alveoli? Depending on where lung particles of medication deposit is how well we can bronchodilate or which parts of the lungs we can bronchodilate with that medication. So it's a really important concept. A major factor in lung penetration by aerosols is particle size. Bigger particles stay in the upper regions of the lungs. Smaller particles make it to the lower regions of the lungs. Extremely small particles under 1 micron in size are so stable and so small you'll breathe them in and breathe them back out. One way to look at particle size is with the mass median diameter or the mass median aerodynamic diameter. That mass median diameter is the particle size above and below which half of the mass of the particles are found. In other words, it evenly divides the mass of particles in a distribution. The particle size that we're interested in is the 1 to 10 micron range. The fine particle fraction is another way that we look at particles. The fine particle fraction that we includes particles only that are 5 microns or less in size. 5 microns or less in size. The fine particle fraction is the percentage or fraction of aerosol drug mass in a particle size range with a high probability of penetrating into the lower respiratory tract. And so that's why these particles are smaller in size, 5 microns or less. So let's talk about count mode. Count mode is the most frequently occurring particle size in a range or distribution of particles. Count median diameter is the particle size above and below which half of the particles are found. The mass median diameter is again the particle size above and below which 50% of the mass of the particles are found. Another term you need to understand is the geometric standard deviation. It measures the dispersion of a distribution, and it's calculated as the ratio of particle size below which 84% of the particles occur to the particle size below which 50 or half of them occur in a log normal distribution. This ratio determines how spread out the particles are in relationship to their size. There are two ways in which we measure the diameter of aerosols. One way is cascade impaction. This measures the aerodynamic diameter of aerosols. It's based on the aerodynamic behavior of the particles in the cascade impactor. This is a more common way for us to look at particle size and measure particle size. The laser scattering method is not as common. It's an instrument that determines the relationship between the intensity and the angle of the light scattered from a particle, and then calculates the particle size based on that MIE scattering theory. Yeah, that's a lot of physics, but again, this is something that would be done in a laboratory and for research, and it's much less common for us to use, but you need to know that that's how we do some of our research in respiratory care. Particle size and lung deposition. So again, this is a relationship between the size of the particle and where it actually deposits in the lung. It is a major factor that influences where that medication takes effect, and so it's of interest to respiratory therapists. Particles that are greater than 10 microns usually deposit in the nose and the mouth. Particles that are 5 to 10 microns tend to deposit in the upper airways and the early airway generations. Racemic epi is one of those that we would want particles of more particles in the 5 to 10 micron range, because we want that racemic epinephrine to deposit in the upper airways, because those are the airways that are affected. In the lower respiratory tract, the size range that we want for bronchodilators, albuterol and things like that, is particle size from 2 to 5 microns. Those are going to deposit in that all over the lower respiratory tract. And to get all the way down to the lung parenchyma, including the terminal airways and the alveoli, particles have to be 0.8 microns to 3 microns. My favorite micron size, just so you know, is 2.5 microns because that will get into the lower respiratory tract and also hit the lung parenchyma. So, what is Jill's favorite particle size for respiratory drugs? 2.5 microns. And you'll get asked that by Miss Lita and some of the other instructors. Let's talk a little more about fine particle fraction. This is the percentage or fraction of an aerosol drug mass in a particle size range with a high probability of penetrating into the lower respiratory tract. So what is that particle size range that gets into the lower respiratory tract? Particles that are 5 to 6 microns in size will get into that lower tract. There are 3 mechanisms of deposition that we're interested in. These are physical properties that are usually considered for aerosol particle deposition in a human lung, and they include inertial impaction, gravitational settling or sedimentation, and diffusion or Brownian motion. Let's look at inertial impaction first. This is a function of the particle mass and its velocity. So how fast is it going and how much gravitas does it have? This increases with larger size and higher speeds. In the upper airway and early bronchial generations, the particle velocity the speed is the highest. Airflow tends to be turbulent, so really choppy, like a choppy stream, and the total cross-sectional area of an airway is small. We expect all of these things to happen in those first 10 generations of the airways. So basically, if you have fast speeds and big particle sizes, they're going to deposit in the upper airway. They're going to stick in the mouth and in the upper first 10 generations of the lung. Now let's talk about gravitational settling. This is also called sedimentation. It's again a function of particle size, but also of time. Settling is greater for larger particles with slower velocity. The rate of settling is proportional to the square of the particle size. And the use of a breath hold, and this is what's really important to you, the use of a breath hold, so getting your patients to hold their breath to a count of 10, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, can increase the settling and get particles to deposit where we want it. Let's talk a little bit about diffusion or Brownian movement. Brownian movement is molecules that tend to vibrate. So this affects those tiny particles that are less than 1 micron in diameter. And again, it's a function of time and random molecular motion. The importance of diffusion for lung deposition of therapeutic aerosols is debatable because the size range involved contains so little drug mass and is so stable. So what is the effect of temperature and humidity on particles, on aerosol medication particles? The particle deposition with therapeutic aerosols is complicated further by the fact that the aerosol is generated under relatively dry ambient conditions, or dry. It's generated out in the room, which is dry. We have very little air inside in our ambient or room temperature conditions, but then you breathe it into the airway where the temperature and the humidity rapidly increase to complete saturation at body temperature, 37 degrees Celsius. Inhaled drugs tend to readily absorb moisture, and between the ambient temperature and the body temperature, the particles can tend to stick together if we're not careful. We've talked a lot about the physical properties of particles, but let's talk about how we generate those for drug delivery. Some of the common devices for delivery of inhaled aerosol drugs include small volume nebulizers, pressurized metered dose inhalers, or MDIs, and dry powder inhalers, or DPIs. This is a typical teacup neb pictured here. Nebulizers encompass various different devices, and they operate on different physical principles to generate an aerosol from a drug solution. A small volume neb is a type, pictured here is a type of aerosol generator that converts liquid drug solution or suspensions into aerosol particles. There are different types of small volume nebulizers. There are pneumatic nebulizers, like the teacup nebulizer. There are vibrating mesh nebulizers and ultrasonic nebulizers. So let's take a look at some of these different types of nebulizers. We'll look at pneumatic nebulizers first. So let's talk about small volume nebulizers, or pneumatic aerosol generators. They have a very small reservoir. You can see that pictured here. They are gas powered, so they're powered by compressed air or oxygen. They're very common for giving things like albuterol and other aerosol drugs. However, they have a large amount of drug waste. They use the jet shearing principle for creation of an aerosol from the drug solution. And the jet shearing principle is an external source of compressed gas is directed through a very narrow opening inside the reservoir cup. The expanding gas creates a localized negative pressure and draws the drug solution up feeder tubes. As the liquid enters the gas stream, droplets are formed from gas turbulence and impaction on baffles inside the nebulizer. Smaller particle sizes are emitted after the baffling process. Larger particles are recirculated back into the reservoir. There is significant evaporation of solution with gas-powered nebulization. There are 4 categories of pneumatic jet nebulizers: a jet nebulizer with a reservoir tube, a jet nebulizer with collection bag or elastometric ball, breath-enhanced jet nebulizers, and breath-actuated jet nebulizers. Next, we'll talk about mesh or vibrating mesh nebulizers, or mesh nebs. I happen to really like mesh nebulizers. You can give an uh, of treatment on a ventilator without adding any gas into the system, because these use a vibrating mesh at the bottom in the nebulizer cup. These don't require a gas source. They're usually battery or electrically powered. The liquid formulations move through a fine plate or a mesh with multiple small holes to generate the aerosol. There are a couple of types. There are both passive and active vibrating mesh nebulizers. The two types are pictured here that are most common. They're used by patients for home use. These are great and battery powered, or they're used by respiratory therapists generally when we want to give a inline nebulizer treatment without adding into a ventilated circuit or a closed circuit system. Ultrasonic nebulizers. Ultrasonic nebulizers have come a long way. They're electrically powered devices, and they operate on the piezoelectric principle. They're capable of a very high particle output, and small portable units are now available that can operate on direct current or DC voltage. This is one of those small portable units pictured here. So this is suitable for all ages. It's compact and it's portable, and it has a dual airflow control, and it's very quiet. So some of the factors that affect jet nebulizer performance are how much residual volume is left, or dead volume, the filling volume, so how much solution does it take to fill it, and how long does the treatment last or take. Some nebulizers, like the teacup neb, take 5 minutes or less. They have very little residual volume, and at flow rates of 6 liters or less, a volume of 3 milliliters is very, very quickly resolved. Let's talk a little more about flow rates and pressure. At 6 liters per minute, for some nebulizers, a volume of 3 milliliters requires less than 10 minutes, and that's a preferable flow rate. At 10 liters per minute, a volume of 5 milliliters can be nebulized in about 10 minutes. Optimal rates are a filling volume of 5 milliliters and a flow rate of 6 to 8 milliliters for many nebulizers. But again, this will vary by the type and how it performs, so you'll have to look at the package instructions. Other factors that affect jet nebulizer performance are the type of power gas. Uses of gases other than oxygen or air, like heliox, can change the performance characteristics of a nebulizer, so be careful if you're using heliox with an asthmatic. The device interface, or how it is given, using a mask or a mouthpiece, also can affect performance. Ideally, you use a mouthpiece, but masks can be appropriate in some situations, and one is pictured here with a small child. The type of solution can affect performance. Droplet size of nebulized solution is related to surface tension and viscosity of the solution, or how thick and sticky that solution is. It's also related to how the baffles in the device are engineered. So on type of solution, for example, higher viscosity antibiotic solutions like gentamicin that you might give a CF patient require power gas flow rates of 10 to 12 liters to produce small particles that are okay for inhalation with some jet nebulizers. Pressurized metered dose inhalers, or our boot-shaped MDIs. These are really, really commonly prescribed for patients with asthma and COPD, especially teenage to adult patients, but you can also use them with a mask spacer. They are small pressurized canisters that we use for oral or nasal inhalation. You may be familiar with Nasacort, things like Nasacort, or things like an albuterol MDI. They have 5 components: the canister, the propellant, how they're formulated, a metering valve, and an actuator and dose counter. Here's a picture of a patient using a metered dose inhaler with a spacer, and a therapist giving him instruction on spacer use. Pressurized metered dose inhalers. Some of the advantages are they're portable, light, and compact. They're easy for the patient to carry. Drug delivery is very efficient, treatment time is short, and they're easy to use. Most of them come with more than 100 doses, anywhere from 100 to 250. And fine particle sizes are available in most HFA or hydrofluorocane formulations. However, there are some disadvantages. There are some disadvantages to using a pressurized metered dose inhaler, or MDI. It can be hard for patients to coordinate, and a breath hold is required to let those particles settle down in the lower airways. Drug concentrations and doses are fixed, and canister depletion is difficult to determine. So it's hard to tell if you have an empty canister unless there's a counter on it. Some patients do have reactions to the propellants, just a small number, and lots of particles. You'll lose 50 to 80% of the medication if you don't use a valved holding chamber. Also, there's a chance for aspiration of debris from the mouthpiece. So let's talk about the different types of metered dose inhalers that are available. There are 3 categories available: conventional metered dose inhalers, breath-actuated metered dose inhalers, and a soft mist inhaler. The category should be paired with the right patient, and you should use a spacer or valve holding chamber to help overcome patient limitations. And again, you'll lose 50 to 80% of the medication if you don't use a spacer or valve holding chamber. Let's talk first about conventional MDIs. It has a press and breathe design. When the canister is depressed into the actuator, the drug propellant mixture in the metering valve is released under pressure. The liquid propellant rapidly expands and vaporizes. The expansion and vaporization shatter the liquid stream into aerosol particles, and those are inhaled by the patient. So breath-actuated MDIs, how do they work? Well, they offer an alternative to conventional MDIs for patients who find it difficult to coordinate the actuation with an inhalation. here is pictured as the Easy Breathe inhaler. A pressurized meter dose canister is triggered by a spring through a triggering mechanism activated when the patient takes a breath in. And soft mist or Respimat inhalers. These are propellant-free and they utilize a mechanical energy in the form of a tension spring. Depressing the dose release button releases energy from the spring, forcing the solution to the mouthpiece and producing a soft mist of aerosol lasting 1.5 seconds. These can be especially useful in older people that are still able to push the button but may not be able to actuate a conventional meter dose inhaler. Factors affecting meter dose inhaler performance include loss of dose, shaking the canister, timing actuation intervals, loss of prime, storage temperature, nozzle size and cleanliness, and breathing technique, as well as patient characteristics. So always ask your patient how they're taking their metered dose inhaler. This is one of my favorite pictures that from a patient saying, "Oh, I know how to take that." And then you have her having her demonstrate, and she's depressing the device and spritzing her neck rather than using a metered dose valved holding chamber and breathing in the mist. The patient needs to shake the canister, they need to prime the canister, they need to store it at room temperature, and they need to keep the metered dose inhaler clean. They need to be able to breathe in and hold their breath. Dry powdered inhalers are good for a patient that can breathe in sharply. They are breath actuated, but you need an inspiratory flow rate between 30 and 90 liters per minute. And some of our younger, very young or very old patients may not be able to do that. However, they're great for older children, teenagers, and young adults. There are three categories of DPIs: a unit dose DPI, a multi-unit dose DPI, and a multiple dose DPI. So advantages of dry powder inhalers are similar to metered dose inhalers in that they're small and portable. They don't need much preparation or administration time, so this patient can take them very quickly. They're breath actuated. There's no need for a valved holding chamber or hand to breathing coordination. There's no inspiratory hold or head tilt, and there's no propellant, so it's environmentally friendly. There's no cold freon effect that may cause bronchoconstriction or inhibit a full inspiration. And it's simple to determine the remaining drug doses because there's always a built-in dose counter for DPIs. Disadvantages. Not all drugs come in DPIs, and patients don't always know the dose they inhale and may distrust inhaling a dry powder. You have to have moderate to high inspiratory flow rates in order to disperse the powder. and they still will impact the oropharynx and the mouth. So with DPIs, especially steroid DPIs, patients need to know to brush their teeth, swish, and spit to get rid of any deposit in their mouth so that they won't get thrush. A device such as an aerosolizer is a single-dose device and must be loaded before each use. DPIs are vulnerable to ambient humidity. So if you live in a high humidity area like Florida, or exhaled humidity into the mouthpiece, powders can stick. It's better to keep them inside in a relatively cool and dry place. Different DPIs are needed for different drugs. All DPIs are not the same. They are easy for patients to confuse directions for use with other devices. So they might they might confuse their metered dose inhaler and their dry powder inhaler. Factors that affect drug performance delivery for DPI include intrinsic resistance, inspiratory flow rate, humidity, and clinical efficacy. So how do you select an aerosol device? Some things to think about when you're selecting that device is what devices come with the drug that you want. Albuterol has a lot of different ones, but cromolyn sodium doesn't. So is your drug available in the device that you're thinking about? What device is the patient likely to be able to use properly given their age and clinical setting at home or in the hospital? Do they have help or no help? And which device and drug combination does their insurance reimburse? Reimbursement isn't the same for all devices. Which device is the least expensive? A nebulizer of albuterol may be less expensive than a metered dose inhaler, but maybe they're on the go and a metered dose inhaler is small and easily portable. So you've got to think about all those different things. So when you go to select an aerosol device, some things to think about are, can the patient use the same device for all inhaled drugs that they're taking? Which device, like a nebulizer, can be used for multiple different kinds of drugs? Which device is the most convenient for the patient or family? Are they on the go? Do they need something small and portable? And how durable is the device? Does the patient or practitioner have a specific device preference? So if you're working with a physician, they may have a specific device preference, and make sure that you find out. Be sure that you look into the pertinent literature about each of the different devices and develop a recommendation for clinical use and use it to develop a clinical use. So do your research. In other words, do your homework about each of the devices that's available. Some factors to consider: patient or clinical preference, convenience of the device, practicality of the device, durability of the device, how much does it cost and does insurance pay for it, drug availability, and the ability of all prescribed drugs to be delivered by the same device. More factors to consider are, where is the lung deposition and loss with traditional devices? So for a metered dose inhaler, a traditional metered dose inhaler with CFC, there's about 8.8% deposition. With a metered dose inhaler HFA, there's 53% deposition, and that can go up with a spacer. A CFC device with a spacer doubles the deposition to 14.8%. With a small volume nebulizer, there's about a similar deposition as an MDI with a spacer, about a 12.4% deposition. And with a DPI, the deposition is 14.8 to 27.7% deposition. Traditional aerosol devices deliver approximately 10 to 15% of the total dose to the airway. So a few final thoughts. A metered dose inhaler with a holding chamber and a nebulizer were equally effective in the treatment of adult and pediatric patients in the emergency department and as inpatients. Both modes of delivery improved symptoms and lung function. However, there's very little information to show that a DPI is as effective as an MDI with a holding chamber or a nebulizer for the delivery of short-acting beta-2 agonists like albuterol. Be sure to follow age-appropriate guidelines for use of DPI and MDIs or the device, and then look at how the device is being given. Do you need a face mask? Do you need a mouthpiece? Should you give intermittent positive pressure breaths, or do you need to give the medication on a ventilator? That will depend. So mesh nebs, great for mechanical ventilators. Blow-by, you lose almost all the medication. A face mask is preferable for a nebulizer or a valved holding chamber with a young adult. And intermittent positive pressure breathing can give a bigger breath and help. Thank you for your time and attention. This is the end of the lecture. I hope you've enjoyed it. Please feel free to let me know.